The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a case of harassment.
What's happening with this individual practitioner that they are so far off the rails?
That's Dr Jillann Farmer, the Chief Executive Officer of A Better Culture, the coalition of health professionals working to eliminate bullying, harassment and discrimination in the healthcare workplace. Jillann is also a former Deputy Director General of Queensland Health, and I'm presenting her with a difficult scenario.
These behaviours are so far outside the normal guardrails of civil society, let alone a professional culture.
In today's scenario, during ward rounds, a senior consultant often raises their voice with young medical staff, making observations that if they had an additional neurone, it would be lonely. They regularly roll their eyes in response to hesitancy in answering questions, and at times indicate that the young doctor's suggested treatment had just harmed the patient. They make inappropriate comments about young nursing staff, commenting on their attractiveness and saying that their partner must be a lucky fellow. They create disparaging nicknames for their registrars based on their gender and race. When senior nursing staff indicate that these comments are inappropriate, the consultant laughs and says it is all in fun and we need to have some levity to lighten the mood around this depressing place. I started by asking Dr Jillann Farmer what primary issues this scenario raises.
There are myriad challenges, but the thing that comes to my mind first of all is this consultant actually okay? Because these behaviours are so far outside the normal guardrails of civil society, let alone a professional culture, that it suggests that the person has profoundly impaired judgment and insight. And one of the things that I always reflect on is that we tend to make an assumption that if someone misbehaves with colleagues, that somehow our relationships with patients are so sacrosanct that even the most egregious recidivist practitioner will always remain professional with patients. But I have real reservations about that. And my view on it is that if a practitioner is prepared to demonstrate with blatant disregard for norms such behaviours, one of my really big questions is what is happening in the privacy of a consulting room with patients as well. So I always think that one needs to look at it sort of from a multidimensional perspective. First of all, there is what's happening with this individual practitioner that they are so far off the rails. What is the impact of that on their team and what emergent actions do I need to take to protect people from this? And do we actually have any risk to patients from a person who appears to have little insight about how their behaviours may impact across power dynamics and in relationships with people who are vulnerable?
So these are all anecdotes at the moment. How do you confirm that the stories are actually fact-based?
So I think that there's a definite place for, informal inquiry, and faced with sort of informal allegations previously, I do find it very helpful to directly approach people who may have knowledge. And it sounds as though that nurses have expressed concern, and nurses are often a very good source of information because they operate outside the reporting lines. one needs to be cautious around just accepting assertions from one professional cadre because there can be interprofessional rivalries. And I certainly have seen clinicians whose practice approach challenge some of the nursing paradigms. I've seen a practitioner like that effectively workplace mobbed. So I would start with nursing, but then I would drill through some additional layers. Depending on the hospital and depending on the reporting lines, I like to reach at least one layer below my direct reports. So if this practitioner was one of my direct reports, there's a high probability I would have a pre-existing relationship with the staff who report to him. One of my favourite practices is to regularly check in with the direct reports of my direct reports, because I have had the experience of what I call a kiss up, kick down manager, someone who, from my perspective in the organisation, was amazing, warm, kind, supportive, but the experience of the people below them was anything but. So one of the practices that I have instituted now across several decades of my career is to do what I call leapfrog interviews. And I put it to the practitioner that this is a professional development opportunity for them, that I will collate it into formative feedback, and then I interview everybody that reports to them along the lines of a coaching quadrant. You know, what's going well with this person's supervision? What do they need to do more of, less of? And, you know, what would you suggest that they do differently? My experience of this is that the benefit of doing it in individual interviews is people are honest. The benefit of doing it as a cohort means that they know that their feedback will be anonymised and that there's safety. It relies on trust. But then I get usually lots of positive feedback, which is really important to be able to identify strengths. Strengths-based performance management is the go. But then if there are things that come up in those interviews, whether it's the first time I've done them or, you know, it's a part of a regular habit, I can present that to the person in a much more supportive way than just going up to them going, you know, people are gossiping about you, pull your head in. That's not a good approach. So I tend to try and take a more holistic approach, collecting data from several sources and then aggregating it into a more summative feedback. My experience, though, you know, it is something that people find sometimes very hard to get their heads around. When something's going wrong, they just want to leap in with the bad feedback. None of us do well under that. And our goal is actually to preserve the career of this person if we can and get them back to a position where they're functioning as a valued member of the team.
One of the challenges in an organisation like this, where this type of behaviour has been going on for a long time, is to set an organisational norm. Mm-hmm. What are the behaviours that are expected, or probably more importantly in this case, what are the behaviours that are unacceptable in your organisation? How do you go about setting the norm?
I think you just have to be really clear. And it's fascinating to me. I was presenting at a conference not too long ago, and I decided to just take a risk and put this out there. And I just said, it is never acceptable to shout in the workplace unless it is a matter of immediate patient safety. Otherwise, it is never acceptable. And I don't care if you're feeling frustrated. I don't care if it is a stressful situation. You can't decant your stress onto other members of the team. What was fascinating to me was that clear statement, shouting in the workplace is never acceptable, removed all excuses and nuance from the conversation. And it followed that person after person then in the sort of the interactive session that followed stood up and said, oh, you know, I don't think I shout. No one stood up and said shouting is okay. And so I think that it is a really important thing for the leader to be able to define shouting in the workplace is never okay. Commenting on people's personal appearance and personal life is never okay. And if you know, is quite possibly the case when you're dealing with a broader cultural agenda, this is normalised behaviour in the workplace, I would actually pull the senior staff together and I would set out those go and no-go, or effectively, you know, above the line, below the line behaviours. There's lots of different terminology for it. Where I have seen this done really actually very well was when I was working at the UN. The Secretary General used to pick one key thing every year that was a key topic that he wanted to reach all of the staff on. And the organisation would prepare a sort of a supportive pack that had a video from the SG in it, but there would be discussion pieces and a facilitator's guide and everything to roll this right through the whole organisation. But it would focus on a core element of behaviour. So, for example, one year it was on managing conflicts of interest. Another time it was on sexual harassment. So if you have a very big organisation, a cascaded approach like that, where you clearly set the expectation for managers, I am having this discussion with you, you are going to have it with all of your direct reports, and you are going to report back to me when this is finished, and this is in your performance agreement, and you will be accountable for it, sends a very strong management message. I think that we're often a bit waffly about we have a code of conduct and, oh, yes, everybody has to obey the code of conduct. But sometimes it reminds me of an experience I've had in a dog off-lead area where someone's dog might be attacking people and their owner stands there waving their arms going, Fido, stop, oh, stop. But there's no effective intervention. It's one thing to say you have a code of conduct, but there's another to be very clear that there are no exceptions to that doctors are not special when it comes to the code of conduct, that there will be accountability, and our expectation is not just around their individual behaviour, but that they demand appropriate behaviours from everybody in the team. So it's about clear leadership intent, and that's something I keep coming back to over and over again. If you have a culture problem in your hospital, you have to look in the mirror, because it is the behaviour you walk past is the behaviour you accept.
I really like your point that the behaviour has to be explicitly called out. You cannot shout in the workplace. It's measurable, it's reportable. Making a complaint can be really risky in these sort of situations. Nobody wants to be shouted at. How do you make it safe for staff members to make a complaint when those staff members are likely to be interacting on a daily basis with the complainant or the person they're complaining about who could take further action?
So the methodology I described earlier addresses that in part. It's about seeking aggregate feedback and people knowing that they have the safety of being feedback in a group, and also knowing that any specific negative feedback is unlikely to be reported back to the person unless it's corroborated by multiple people. So that if a person is worried that only their individual experience would identify them as the complainant, by doing sort of a more generalised solicitation of feedback and by making sure that things that are reported from multiple different data points, you give it a degree of cover. That's not a suitable methodology, and the anonymity is much harder when you have to move into a formal process where there's a formal complaint and a response. And based on the report that A Better Culture commissioned earlier around where we got qualitative data from a whole pile of senior RACMA fellows, one of the big challenges is how quickly people reach for a litigious response, that they can feel besieged immediately and that they can think that the way out of this is to threaten and, initiate a countersuit. So managing things sensitively is a critical part of it. One of the things that A Better Culture is working on, so I don't have an answer for you yet, is this concept of safe reporting pathways. There are the models that are derived from the Vanderbilt model. St Vincent's had the Ethos program. The Cognitive Institute had, I think, Speaking Up for Safety. I know that the Marta group are implementing Courageous Conversations. All of these are designing ways to support people to have the conversations that they need to have, and where it's necessary to do so, to provide them with a way to make an anonymous report. The data on them is relatively mixed in terms of their impact on the effect of that for doctors in training. It seems that doctors in training are still reluctant to put things up and are going to require a lot more support to do that. I think that the issue of doctors in training remaining silent is far more profound than simply the issue of fearing retribution. I think we have a really significant difficulty with the socialisation that occurs early in careers, where we take people who have been amongst the best and brightest in their peer groups, often peer leaders, and we grind them into a subservient, obedient role where they're taught that the seniors are right no matter what, and it must be, yes, Dr. Smith, no, Dr. Smith. They don't even get taught that it's okay to use people's first names, which is quite bizarre in Australian workplaces in the 21st century. So whilst it's easy to say that doctors in training are not speaking up because they fear repercussions, I actually think even if we remove repercussions, we may not get them speaking up because of that ramp of socialisation into deference that we are achieving as a profession, and that I think we have to get rebalanced. We need people to respect authority and not go outside their scope, but we also need to make sure that people don't lose their fundamental sense of self and their right to have a safe workplace. That's going to be a complex piece of work, and we're going to be publishing something on it very soon.
That'd be great.
So how do you approach the specialist?
My personal preference is, in the first instance at least, to have it be a one-on-one. That's my personal preference. And my reasoning for that is that the more people are in the room, the more you send a signal that this is a formal process and litigation is inevitable. So I think it's that balancing act. And I think that a coaching conversation is very reasonable. You can make notes immediately after it. You can work from a script. You know, there are methods that you can use to prevent yourself from being accused of saying and doing inappropriate things. And I think I would approach it with curiosity. And I think that that's one of the things, that asking questions can often get you further in a conversation than others. And I would potentially just want to ask them some questions about how things are going, how are they finding the juniors, have there been any conflicts with anybody? You know, see if I can get them to surface from their point of view what has been happening, because even though I think I've done my due diligence, I haven't yet stood in the centre of the circle and looked at what's happening for them. And, you know, for example, I have had an interaction with a doctor who was an overseas trained doctor from a different culture. And the story from his point of view was one of vilification and racial abuse. It was awful. It was truly dreadful. So I think that you have to make inquiries with an open mind and understand that the perspectives from others will be different, but we're working towards resolving it. If that initial conversation was met with responses that escalated my concern or made me feel that a formal response was necessary, I would then take the next step, and that would involve probably a more formal meeting, perhaps with HR present or with my boss present, whoever. Again, it all depends on individual organisations, and that's why I can't really give blanket recipes, because every entity has their own policies and procedures. But in summary, my approach would be, if I can, certainly keeping the person who would be involved in stage 2 advised, let them know that this is what is happening, so that if it doesn't go well, I can go back to them and they're not suddenly going, "What were you doing?" I tend not to ask lawyers permission to do things. I tell them what I'm going to do, and I ask their advice for how to manage the risk of that situation. Often the advice you get will be advice that hamstrings you very significantly, and you can start to learn some helplessness in these situations. So work out what you think you need to do your own assessment of what you think the risks is. By all means, bounce that off someone, but be prepared to hold firm and say, this is what I need to do. This needs to happen. Help me manage the risk. Don't ask permission.
So what do you do with the doctor that's clearly got no insight? You talk to them and say shouting is inappropriate, and they shout at you and tell you they never shout at all.
I have had exactly that experience, David. I have had a doctor standing over the top of me, literally yelling, "I do not shout!"
Yes.
And I just said, "What are you doing right now?" And it was just like, you know, there is that moment of realisation. Nobody wanted to be the shouter. So the lovely thing for this practitioner to do is, first of all, establish if they want to be the shouter. They probably don't want to be, because they're saying that they're not. And then see if they could contemplate giving someone permission to just say, "Hey, you're shouting." You know, to create a feedback loop in the workplace that they have created permission for, because that makes it an immediately much lower stakes thing. Or even if they don't want that feedback to be explicit amongst others in the group, you know, like maybe with their juniors, maybe they would have this arrangement with the NUM that they might have known for many years and have a good relationship with. And they can say, "Oh, look, you know, Stacey, I've realised that I've developed a terrible habit of shouting and I really need to stop it. Can you just, you know, tap me on the shoulder if I'm shouting?" Or, you know, get them to give you a signal so that you get an immediate feedback loop that you've given permission for. Now, if that doesn't work, obviously we need to escalate it. But behaviour change is always more successful when the person whose behaviour you want to change is in charge of it. And so if they want to stop shouting, help them find the tools to get the feedback. If they want to stop making inappropriate jokes, they really need to develop some other ways. So even some pre-planning of other forms of humour to lighten the moment. And often the best way to do that is to crack fun at themselves, not other people. So, self-deprecating humour is usually very safe. Deprecating others is very rarely safe.
One of the challenges is that this sort of behaviour becomes part of a team and everybody else is looking on to see what you're doing to try and control this practitioner's behaviour. How much can you tell others who are involved about what you're doing?
You can't tell them anything, and that's one of the great challenges. People have a right to privacy around performance management, but you can do group interventions that everybody is involved in without that being about the individual, because honestly, it's very rarely about an individual. The people who are sitting in the stands chomping on their popcorn, they're accountable as well, because they've been sitting there chomping on popcorn instead of taking steps to manage the behaviour. So I would actually have pretty limited tolerance for the spectators in this situation if they have been allowing it to go on for some time. This is not just a Dr. X problem. This is a team problem. And I might even look at starting to implement some formal team evaluation tools and interventions. Sometimes if you've got a team that have moved a long way into dysfunctionality, the use of, team evaluations and even an external facilitator can be extremely helpful.
It's often the nurses that are the victims. Nurses report to the Director of Nursing rather than to medical services. How do you collaborate with nursing in...
It's interesting you say that, David, because in fact, when you said who else would I talk to, I forgot to mention I would be talking to the Don at the outset, because they're usually very, very good at the HR stuff. They've often had a lot more exposure and experience to it as they go up their career path. So the Don would be fully apprised of what I'm doing, but I wouldn't hesitate to express concerns about an enabling culture that I might see the nurses participating in. There's some evidence in the medical training survey that nurses and allied health give female staff a harder time and they accommodate male bad behaviour more frequently. So I'd also be looking at other data points as well that I could sit down and discuss with the Don, and preferably approach it as an executive team, even looking at allied health, because allied health can often witness things that others don't.
There's a victim in these scenarios. It's very traumatic to be a victim of bullying and harassment. What support would you offer to the victims in these cases?
So there are many victims in this case. There are many, including perhaps the practitioner at the centre of it all, who perhaps may well just be passing down the generations' behaviour that they experienced themselves as a junior. So I think it's important to look at it holistically and be alert to the second victim phenomenon. And look, I am not a fan of just telling people to contact the EAP. We have reasonably good data that shows that doctors are not keen to contact EAPs. They often feel, and sometimes with just cause, that the EAPs operate at a relatively low level without understanding the complexity and might do well in a situation that does not have this complexity. So it really would depend on what the support was that I thought people would need. I am not a fan of just telling people to go and see their GP. Whilst I'm a staunch advocate for every doctor needing to have a GP, I think dumping workplace issues in the lap of a GP is just wrong. So I've told you what I don't think works. I think it's actually a complexity of things that works. So line management support is the absolute minimum. It's the absolute minimum. And so if the line manager is the issue, then that's where I, as the second reporting officer, step in and have to provide support, and I may mobilise some either peer support or professional support that is a little bit more bespoke than what I had specifically, like just telling them blankly to ring EAP. I might ring EAP myself and see if we can identify a more appropriate practitioner to participate or to support staff. I wouldn't want to just throw people into just the random selection of an unidentified practitioner. If you bring an org psych in, they will often have a network of people that they can access to who may have a more nuanced and sophisticated understanding. Then, of course, the place that the GP comes in is with the assisting and treating of if things have evolved to the point where people actually have a diagnosable mental health harm as a result of this. Burnout is more likely to occur in these situations, but so are depression and anxiety and actual full-on clinical syndromes of depression and anxiety. So people who have been through this may well require both medical and psychology treatment. They may well need a period of sick leave away from the workplace, depending on the harm. But it is important that, putting my occupational health hat on, it's important that not become the coping mechanism, because once you institutionalise absence from the workplace, and the longer that goes on, the harder it is to get people back to full functioning. I think that Australian health practitioners are really underserved in terms of occupational health services. And if we had robust OC health services operating just as a norm in Australian healthcare workplaces, the OC Health Service would be who I would mobilise to support this. Instead, we put together this patchwork that I've talked about previously. But for example, in France, if you're an entity that has more than a certain number of staff, it is obligatory for you to have an occupational health service.
A good occupational health service would have identified this issue a long, long time ago.
Yes. And they would have facilitated the reporting and the feedback and everything. So I'm on a bit of a campaign to elevate occupational health services, because I think one of the reasons that it has been neglected is that we've been doing it ourselves and doing it with varying degrees of success for a very long time.
Jillann, a great conversation. Thank you so much for it. Do you have any final thoughts on this sort of scenario and process before we wrap up?
I think, my overarching thought is to look at everybody with curiosity and empathy, even the alleged perpetrator, because the more cases like this I have dealt with, and I have dealt with many, the more I approach those initial conversations, the more I uncover the pain and vulnerability of the perpetrators as well. And we need to keep that in mind and seek compassionate resolution, but also recognise that we can't always save everybody all the time, and we have to create safe workplaces.
That was Dr Jillann Farmer, the Chief Executive Officer of A Better Culture. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.